So thank you again, everyone, for joining. And it's my pleasure to introduce Heather Kenny, who will be presenting this evening. Heather has been practicing dental hygiene since 2005. She's practiced in many areas of dentistry, including general private practice, DSOs, periodontology, and biological and holistic-based practices. Heather currently enjoys practicing as a biological oral health coach, where she assists Bristle clients and private clients in creating oral health routines based on salivary testing results. As an HIAOMT certified hygienist, she's gained a knowledge on the oral microbiome through the use of phase contrast microscopy, salivary testing, along with studying many aspects of disease processes in the mouth, including nutrition, airway, and gut health. Heather is a support coach for practices who are utilizing Bristle salivary testing and enjoys helping dental professionals become leaders in dentistry through true prevention. So without further ado, I'll turn it over to Heather.
Thank you, Brian. All right, awesome. So I'm so excited to be sharing the Bristle testing with you today. So thank you so much for joining us. And I try to make this as a case study front learning as possible, because I know lots of people have questions about how to use the test and then implement treatments, both home care and within office, and how that can kind of give you an ROI on using the test and improving your outcomes within the office. So we'll get started. So today we'll discuss why the standard of care currently that we're doing is not really addressing root cause of oral and systemic pathways of disease. It's more reactionary, I call it, dentistry versus prevention, even though we call it preventative dentistry. We'll explore how the Bristle test offers a better understanding of oral dysbiosis or imbalances within the oral microbiome, and how we can promote a truly preventative care versus that reactionary process. So we will learn how to navigate some of the platform. If some of you haven't seen our platform, it'll be an introduction to the platform. And then really focusing our preventive care based on the bacterial risk versus the presence of disease. And then, like I said, we'll be sharing some case studies today. So I have two really cool case studies. One that I treated within my biologic practice, and I have some really cool outcomes to share. And then one who is actually one of my coaching patients. So I haven't treated him at all clinically, but I've been working with another practice and implementing home care support and education regularly with him. So let's just talk a little bit about the current, I call, reactionary dentistry model. So we have, as hygienists, basically 3 pathways to help treat our patients. Healthy is considered no bone loss, pink stippled firm tissue, and no bleeding, where we use a prophylaxis for treatment, and usually those patients are put on every 6-month recall. Currently now, we finally do have a code to help with gingivitis. Those patients have to have at least 30% bleeding, which I think if 30% of the mouth is bleeding, it's probably not the most preventative process, because if we have bleeding, we have disease already. There can't be any bone loss with anyone who you're treating with for the 43, 46 scaling with presence of inflammation. And then we move into our perio treatment processes where we do have clinical attachment loss, bone loss on the x-rays, inflammation through our perio maintenance and our perio therapies codes that we can utilize. And hopefully everybody's doing a great periodontal evaluation, and that evaluation should be including missing teeth, probing depths, or doing the gingival margin, assessing both the probing depths and gingival margin gives us that clinical attachment loss process. Bleeding and separation is so important for us to be charting as well, and then making sure we're aware of where those mucogingival junctions are. So that's the appropriate way to assess disease presence within the mouth. So right now, for our perio patients, we are assessing the presence of the current disease process. And then same thing with the current treatment model for decay. We're waiting for the drill process to take place through detection of with x-rays. We do a treatment plan and then implement some sort of treatment based on the presence of disease once again. So, and then we might do some preventative. Most of the preventative is trying to go through the remineralization phases We do have some diamine fluoride type of silver diamine fluoride, which helps remove some of the bacterial issues, but not very often are we dealing a lot with the bacterial dysbiosis or looking at what's actually the cause of both of these disease presence in the mouth. So what are you treating if you're not looking? So as Brian mentioned, I did work with a microscope. I've worked in all realms of dentistry. I learned so much by working with a microscope in practice. And I kind of put one of our slides of the periopathology on the side here so you can kind of compare what you're seeing on the slide. But phase contrast microscopy gave me a really great understanding of what was going on in the mouth, but it didn't really give me a good diagnostic. So this is a pretty cool video of what the oral microbiome looks like. Some of us haven't looked under a microscope since hygiene school, but we have our chained rods, our spirochetes, and our spinning rods, cocci. So all of these, when I started using phase contrast microscopy, I didn't really know what an unhealthy slide looked like. I mean, this looked pretty out of balance, but not really as bad as some slides that I may have found. And then some slides that I didn't think were as bad. After doing tests, I realized it was much worse than. So I think phase contrast microscopy gives us a great tool for screening. It gives us a wonderful tool for understanding inflammatory pathways by checking our red blood cells, our white blood cells, if there's any amoebas and things like that. But as you can see on the side here, we can kind of compare what you're seeing on that slide versus the slide here with our testing where Fusobacterium is a chained rod, or Porphyromonas families are generally those rods that are kind of swimming and moving. T. denticola, we all know, is a spirochete. I like teaching on the slides too. I use this for my coaching a lot, just to explain what different things in the mouth we might be using. Like a toothbrush and your floss are really helpful for those sticky biofilm-based bacteria like Fusobacterium, but we really need to make sure that we're incorporating a water flosser and things like that when it comes to those swimming microbes, the ones that are hidden in those nooks and crannies. So I use the test to teach people how things move in the mouth and what sort of tools we may need, and the microscope kind of gives us that option as well. So it's kind of a fun learning tool for both of our patients. And we need to start looking at the oral microbiome in general. So there are over 700 unique microbial species in the oral microbiome. We are the only oral microbiome test that's actually testing for those 700 microbes. And we've had scientific research for decades linking oral and systemic health. And we know that the sooner we address those pathogens, we have less progression of disease. However, in dentistry, we often are using more reactionary and not really focusing on the microbes that are present. So if you're not understanding what you're treating, how can you be successful in your treatment process? And then there are other factors I think that we need to consider when it comes to oral health in general. Obviously, oral dysbiosis, we know certain pathogens like Fusobacterium are tied to colorectal cancer. P. gingivalis is tied to Alzheimer's disease. There's a lot of oral dysbiosis that can cause oral and systemic health. And oral dysbiosis is impacted by salivary pH. We need to be assessing pH, understanding the nitric oxide reduction processes in the mouth. Nitric oxide starts in the mouth by nitrate reduction. That starts with the bacteria that are beneficial in the mouth. And there's a lot of new studies showing that overuse of antimicrobial rinses have a profound impact on those beneficial bacteria. The nitrate reducing bacteria, when you mitigate those, can have impacts on blood pressure. So we at Bristle definitely kind of lean on the lighter antimicrobial side and more on the balancing of the oral microbiome, and really catering to making sure that we're creating homeostasis and not wiping out everything. Mouth breathing, airway, dry mouth, medications, acid reflux, vitamin deficiencies, and metabolic disorders are all tied to oral and systemic health issues. It's a huge relationship with all of those. So the salivary testing can help you kind of put all those pieces together and start really treating the patient as a whole. So the salivary testing basically brings the pathology forward when it comes to treating your patients versus just looking at the disease presence and trying to just scale or wipe out everything with chlorhexidine. Or maybe just, I worked for a dentist who he didn't want to do fillings all the time. So his hygiene department, he was like, try to figure out what's going on so that I'm not constantly replacing fillings from cavity issues. It gives us imbalances of what's causing those dysbiosis, and it helps to treat some of that oral systemic connection. I also want to point out that the salivary testing can also give you better referral processes. So oftentimes what I found in the testing, if some of the pathology might be low, like for instance, nitric oxide, if that's low, you may have an airway issue, a mouth breathing problem, sleep apnea to consider. Or cavities can be the same. You'll have low pathology for decay, and you need to start looking at what the airway is looking like and addressing dry mouth issues, things like that. So I had a really cool case with diabetes where someone had low pathology for their periopathology, but her diabetes A1C was at 14. So you start looking at all the buckets, I call, with the entire body that might be impacting that cytokine and inflammatory response that causes disease in both directions. So it's bidirectional. And we also need to think about, maybe the pathology in the mouth is there and they don't present orally, but do they have other systemic diseases like rheumatoid arthritis, cardiovascular disease, or perhaps dementia and things like that that are starting? And are those tied to the oral pathology that may be present in the mouth? So we can be truly preventive on the systemic side of things as well, because maybe they're not orally presenting, but perhaps those pathology that are present are or do have an impact on their systemic health at the time. So clinical treatments can then be introduced based on the bacterial risks versus the presence of disease. So in our platform, you can pick what the patient might be presenting with. So in the upper corner here, you can see like healthy gum tissues, but maybe their gum inflammation score is indicating high risk, or their tooth decay score is high risk. So you could add adjunctive treatments to this patient to have a better health outcome, even if they aren't presenting with disease. So maybe because the gum inflammation score and the periopathology are high, you would possibly do a laser decontamination or bacterial reduction, or add ozone tray treatments. Maybe your office is doing perioprotect trays, and this person would be a great candidate because they do have the pathology that would be affected by that treatment. And then gingival irrigation. So it gives you the opportunity to really focus and be more specific to what the patient needs based on bacterial risk versus disease presence. And we have a ton of resources. If you don't know a lot about the oral microbiome, you don't have to let it be completely overwhelming. So our resource and support system has a Get Started program where we have a provider university. We have lots of videos and learning tools to learn about the oral microbiome so it doesn't get overwhelming. Book a support call. That's my job, and the CEOs of Bristle do a great job at supporting as well, but you can book a support call with me. I can go through the test with you, help you navigate maybe what treatments and what options you would have if you're struggling with the test to get you started. We really want you to be confident and comfortable with utilizing the test. So that's what I do, is support you in that process. And then we do have in-office care guides and at-home care guides that give you guidance with disease presence and the bacterial risk, and kind of gives you ideas of how approach your patients. So we'll give you guidance for tooth decay and gum inflammation scores based on the clinical presentation and the bacterial risk in both traditional and integrative. So we recognize that we have traditional dentistry who's using traditional methods. Maybe you're using lasers and adjunctive therapies, subgingival irrigation. And then we have the integrative side where we would include the ideas of using ozone and laser and more holistic products. So I do tend to be on the more holistic side when it comes to talking to clients and with offices that are more integrative in nature. So I do, when I have conversations, I like to know what products you like to use and then help you navigate what you have within your office and adjusting some of that, or give you ideas of what to use. And this can include your treatments, your adjunctive therapies, and maybe recall frequencies, and then always retesting frequency guidelines for the clinical guidance as well. And this is just a little example of what some of the in-office treatment guide might look like. So if someone's low, maybe you're going to do a prophy and you do your hand scaling and ultrasonics. If they're moderate risk, perhaps you're going to bring them back for another prophy, similar to a 43, 46, and have a different series until you get that oral microbiome under control. And then high, maybe you're going to implement some scaling and root planing or laser types of treatments and that sort of thing. So it kind of gives you some guidance based on clinical presentation and moderate. And the case studies that I have are variants with each of the case studies that I'm sharing. So it'll be more insight when we get to the case studies that way. But we have some really nice traditional and then also integrative types of planning that you could do based on clinical presentation and what the pathology score might be. And this is another fun little slide that I like to share. So this is a slide that has lots of yeast on it. There's lots of red blood cells present due to mouth breathing. And this kind of gives you a little idea of what the slides give you as far as the inflammatory response that you can see for that. So if you are using a microscope slide, maybe you're going to do more frequent slides on your patients so that you can assess that inflammatory response and understand the relationship between the microbe that you see on your test and the progression of your treatment. There's some white blood cells there. And then we also offer a lot of at-home care information too. So within your treatment planning, you have access to the at-home care as well. I'm a firm believer that no matter what we do within our office, it's a restart. So if we don't have our patients on the right process to keep them maintained, then what we do within the office, is limited. In it's basically pushing the restart, patient education, and making sure that they are able to carry that torch from appointment to appointment is super important. So we are home care focused and really think that balancing the oral microbiome and not wiping it out with tons of antimicrobials is super important. So we do have a pretty extensive two-phase process where we have a weed out phase and then a phase of trying to grow and promote health within the mouth. So I don't know if whoever was in here prior, I'm a big gardener. So oftentimes we talk about the mouth as a garden. And if we're constantly tilling the garden with antimicrobial rinses like chlorhexidine and Listerine and TheraBreath, which I see over and over on the tests, they just wipe out our beneficial bacteria and our nitrate reducing bacteria. And oftentimes pathology becomes high and sometimes monocropped when we're using those types of products. Just like in the garden, if I were to till the garden every single day, I would never have fruits by the end of the summer that would be something that I would be able to can by the end of the summer. So we really we might do a till out phase at the very beginning, just 2 weeks. And then we try to make sure we're growing things by adding in super beets for nitrates and arginine and pH balance and xylitol, changing the environment of the mouth, adding in probiotics. Probiotics I kind of teach are like our companion plants in the garden. So probiotics are super important. Some probiotics help mitigate or correct the oral microbiome by acting as a bactericidin. So it will help kill off the bacteria that are pathogens in the mouth. And they also take up space. So I kind of associate it, like I put marigolds in my garden. Marigolds keep the deer out. They take up space where maybe the thistles would grow, but they bring bees to the garden so that my tomatoes are pollinated. So we use probiotics quite a bit in our care plans. I associate basic bites and super beets and xylitol. Those prebiotics are like readying the soil and keeping the environment ready for the garden to grow. So these are important factors that help balance the oral microbiome. And of course, our daily weeding process: brush, floss, tongue scrape, use a water flosser. I think it's so important for every single person to use a water flosser. Going back to those slides, we have the swimming bacteria. They're usually anaerobic. Water flossing helps to get oxygen below the gum line and in the areas and flush out those swimming bacteria that your toothbrush and your floss just aren't accessing. So let's dig into the case studies. So I think teaching by example is super fun. And I know lots of you have had questions on what do we do with the tests based on that. So this is a really fun case study. Clinical presentation: she's got a couple missing teeth. No significant bone loss areas. And I preface that because she does have a couple 5mm pockets, but if you look on the x-rays where the 5mm are, we have good lamina dura there. It's right at the CEJ. So there really isn't significant bone loss other than where there is a tooth loss. She does have a tongue thrust type of habit, so she does have a little bit of clinical attachment loss from recession on the lower anterior, but no evidence of current decay issues. Health history has frequent tiredness, glaucoma, sinus infections or sinus issues. She has Hashimoto's, rheumatoid arthritis, anemia, kidney disorder, and she's also suffering from smoldering myeloma. So we have quite a few inflammatory types of diseases present, but overall, some inflammation in the mouth, but relatively healthy in the mouth. There wasn't any bleeding when I did that. I'm kind of a stickler when it comes to doing full charting. So in my office, we did guided biofilm therapy. I love disclosing patients. So for this case, let's just talk about what the conventional approach might be. So first off, maybe we're going to do a D1110. So a traditional prophy, because we do have pink stippled firm tissue, there wasn't really a lot of bleeding. She does have 5s, but there's no bone loss and there's no bleeding points. There's the new 4346 code, but because there's no bleeding, she doesn't really qualify for that because we have to have 30% bleeding in order to submit for that code. Some offices would bill out for an SRP in some of these localized areas. But like I said, with the x-ray, there just isn't evidence of bone loss there. So it might not be a covered service. And then you're going to do your exam. Maybe if you're in a traditional office, you're going to do a fluoride varnish because that's what people do. And then put her on a 6-month. Maybe you'll put her on a closer recall based on the periodontal charting. This was her slide. So my office, well, the first thing we did was we take a pH test and then we do a slide on every single patient. So this was her slide. So this was a little bit concerning. We have definite some spirochetes in there. I know spirochetes, usually T. denticola, can be tied to Alzheimer's disease and some other highly inflammatory processes in the body. There's a red blood cell present. There's some cocci in there. With the microscope slide, I always explain this is a screening. I don't really know exactly what's in there. I can kind of guess, but it's more of a screening of the dysbiosis than it is an actual diagnostic process. Given her circumstances with her health, she was one that did want to go ahead and move forward with diving a little bit deeper into the oral microbiome balances because she's struggling with her multiple myeloma and her rheumatoid arthritis and other health issues. Whenever I give a microscope slide, I would always offer that fact that this is a screening. It doesn't give me a diagnostic type of screening to really understand what the pathology is there. So she did opt to go ahead and do the salivary test. So in our office, like I said, we do a health history, always do a pH test. Salivary pH is super important. Anytime we're below 6, then we need to start thinking about whether there's some acid reflux issues or dry mouth problems. It gives us an assessment on someone if they're higher risk for caries. And then also periopathology love to be at a more acidic environment as well. So it makes a more conducive environment for the pathogens we just saw. I always do a phase contrast microscope, oral cancer screening, perio charting. I'm a stickler for doing all of the perio charting we need to do, including recession and bleeding. And if there's any separation or furcation, I try to make sure I have all that noted. In this, if you're not super familiar with what an integrative office is, this is a ozone generator next to the slide information, the Bristle test, and then of course the x-rays. The day that we did the test, like I said, we did the pH, we did the microscope slide, the salivary sample here. This is the code you can use when you take the salivary sample. We always did a pre-rinse after doing the test. Note that if you're doing a salivary test the day of an appointment, you have to do it before you'd start anything within the mouth. So you want it not to be a disrupted oral microbiome. I would take a small sampling of the plaque, usually on the first molars. It didn't seem to be super disruptive, but no pre-rinses prior to taking a sample. So it has to be the first thing that you're going to do if you're going to do a sample chair side. So we always do our ozone pre-rinse. I always use an ozone irrigator. Going back to the water flosser, we always disclose after irrigating there's sticky biofilm-based bacteria that is always present after even doing ozone irrigation. So it is important to make sure that you water floss after your home care routine, not before. And then we utilize guided biofilm therapy. It's more biofilm based when it comes to hygiene. You always disclose you're working on home care processes and then really going after the oral biofilm and then finishing up on calculus removal, because it's not calculus that causes oral disease. Yes, it can cause more surface area for bacteria, but it's not calculus that's causing periodontal disease. It's the pathogens present in the mouth that are causing periodontal disease. So we need to address the biofilm disruption processes when it comes to hygiene. Guided biofilm therapy is amazing. It's life-changing as a hygienist to do. I don't think I could ever clean someone's teeth again without disclosing. If you're not disclosing your patients, you need to. Even if you're doing traditional dentistry, please disclose your patients. You have no idea what you're doing if you're not. Not the most holistic thing because it has red dye, but it's such a great learning tool. When I'm teaching, even in coaching, I honestly, for the first 2 weeks of the care plan, I tell people, use a disclosing tablet and learn whether you are being effective with your biofilm disruption. It's such an important learning tool. You can brush 2 to 3 times a day, but if you don't have your toothbrush at the right angle and you're not flossing properly, you are just not doing the job. And then we finish up with ozone insufflation. So that's what we did. So I obviously didn't have her test results for that treatment, but here are her test results. So I was really surprised because I didn't think her slide was terribly bad, but her gum inflammation score and her tooth decay score were significantly high, and she was at risk of both diseases. So don't let our information overwhelm you in our platform. I always tell anyone I'm coaching professionally, whatever you are looking at for your patient, pick one category and go with that. And then once you retest, then you kind of reassess where you need to go. But usually you're gonna just kind of focus in one spot. So this is the other additional health and wellness insights. So we do have I'm going to just go back to this. If you're not familiar with our tests, we have a number of different health insights we give you. Your beneficial bacteria, your gum inflammation, your tooth decay score. Those are like the biggies that everybody wants to know about. And then we also have a halitosis score. So dealing with what type of halitosis you might be suffering from. A lot of my calls are on halitosis. Gut impact, there's pathology in the mouth that we swallow. Fusobacterium nucleatum has a huge impact on gut health. There was just an article on Fusobacterium and colorectal cancer. If we're not mitigating Fusobacterium nucleatum, which is in every single test, I never don't see, it's always there, Fusobacterium. So, and then a nitric oxide score, going back to that nitrate reduction and how important that is with blood pressure, immunity, actually some insulin resistance issues if you don't have good nitric oxide. So we want the nitric oxide score actually high. And then diversity, which is we want a diverse amount of bacteria. If it's really high, you have a lot of pathology. If it's really low, there's some really cool things we can look into. Sometimes we have just one or two bacteria that have taken over the entire oral microbiome, and we have to start treating that one first. And that's a whole nother conversation. But diversity, we want bacteria in the mouth. We need to stop thinking that we need to wipe everything out. We also have a high risk score, because I know a lot of you who are using other tests really like just to get to the point and want to know more about those red complex pathogens and the caries microbes as well. Even though strep mutans is not the only bacteria in the mouth that causes cavities, but we give you a nice little overview for a quick view of what you might be at risk for with these pathogens. And then, of course, is the oral systemic connections as well. So we give you a really nice overview of the oral associations and the systemic associations when it comes to some of the key pathologies within our test. So this is usually on the first page of our test. So you get the general overview and then these views just to kind of tie in simply what the test means for you and for your patient. But we also offer better guidance as well. So we can give you, there's tabs that you can always open within our platform, and it can give you some talking points. Like I said, if someone is low risk or doesn't have disease presence, but they're high risk, then you need to understand that there's that systemic connection and the risk factor of having the bacteria in there, and long term can cause chronic inflammation and problems within the body and the mouth. So it just gives you some good talking points. And then this is what our basic platform looks like when you kind of dive a little bit deeper. Each of the bacteria that are present in that person's mouth will get the bacteria and a score. The score is based on our general population and where they're scoring in that general population. So they're given a score based on that specific bacteria. So a 9 out of 10 is unhealthy. And then we tell you a little bit about the bacteria. It's gram-negative. It's a chained rod. That means it's a sticky biofilm-based bacteria. It's going to disclose anaerobic, how it might live in the mouth. If it's living within a biofilm or in an area there's no oxygen, I use that a lot to guide me on what products we might want to use in the mouth. Ozone, hydrogen peroxide, chlorine dioxide against anaerobic bacteria are really nice to use because anaerobic means they can't tolerate oxygen. And then we also give you guidance on oral probiotics. So Ruterin sensitive, Planidocerian sensitive, those are telling you what probiotics act as a bactericidin. So what probiotics you might be able to add to this individual's home care routine that will help correct the pathogen present. And then, of course, anytime we want to reduce decay, even if there isn't, it's just going to help the patient as well. So we should look at the whole picture as well. So, and then this is the fun thing. So, like I said, strep mutans is not the only bacteria. As someone who's been working on the oral microbiome I just met my 1-year anniversary working with Bristle. I don't see strep mutans in there, guys. Not that often, not as often as all of the literature says. But I can tell you, Prevotella denticola is pretty common. And oftentimes, if Prevotella denticola is there, your patients might have interproximal decay issues, is what I'm finding. So I know we've been trained our entire hygiene career, dental career, that it's strep mutans that is an issue, but dental decay is a polymicrobial infection that's involved with multiple types of bacteria. So it doesn't have to have strep mutans in there to be high risk. Prevotella denticola is one that has struck my fancy when it comes to looking at it. And then I learned very much in use of my microscope that Candida albicans, if that's high, you might want to check your root caries issue. So Candida albicans is very prominent with root caries issues. So if you have your patients having major problems with root caries, one, check airway and make sure that you're checking Candida and treating Candida. How do we treat Candida? Hydrogen peroxide works pretty nice for Candida. So if you have patients who are struggling with Candida overgrowth, and then I always say a functional doctor is really great to be working with, because if Candida is in the mouth, it's in the gut as well. So we need to treat gut dysbiosis. There's a lot of issues if you have leaky guts and problems in the gut that comes back to the mouth with mineral deficiencies. And poor remineralization, and it shows as bone health issues as well. So the platform can help you with the treatment planning process and give you guidance based on how that patient is edging. So for her, we tried to address everything through using ozone insufflation. And then home care routine. So this was what I called her back. So I get the test about 3 weeks after. It takes about 3 weeks. So I did my treatment. I sent her home with some stuff that I thought maybe we would need. But then once I got her test results and was like, whoa, we definitely have some imbalances here that I didn't foresee. I don't think the prophy was probably the only thing that we needed to do. I work in a holistic practice. We have the ability to do ozone trays, ozone tray treatment. You hook them up to the ozone machine. One end of the ozone goes in, and there's a small suction tube that goes to the suction. And how our process was is I didn't disclose for this because I don't want my trays to die, but I would start with pH, do my slide, and then irrigate, and then do a brief guided biofilm therapy without disclosing to do a nice disruption of the biofilm. And then 1/2 hour on the lower arch with the ozone, bathing the tissues and the teeth. And then we would switch, they would rinse with some ozone water, rehydrate, and then treat the upper arch another 1/2 hour using the ozone tray. So we did that about every 2 weeks for 6 treatments. I say that because she was someone who traveled about 2.5 hours to come see me in the office. So sometimes that timing was off a little bit. She was placed on nitrates, arginine, xylitol, and probiotics. In our office, we had tooth and gum tonic, so that's the antimicrobial that we were using. And then, of course, we made sure she was using an electric toothbrush, flossing, and water flossing. And then I did put her on 3-month recalls because of the risk factors as well. So, and then because she had the trays, now we can utilize those. We know she's high risk, and that's a cyclic type of environment with bacteria. So she has the ability to schedule her prophy appointment, and then after her prophy, we can allot an extra 1/2 hour or 40 minutes to do ozone tray treatments at her recall appointments. And then understanding your outcomes and success is super important. That's the awesome thing about using the test as well. So I think it's so important to make sure that you're implementing a care plan and then testing to see. Not everybody is the same, so you won't always have the same outcomes. Sometimes I have one couple right now, they both had similar biomes. He did not so great. She responded really great, but he has a lot of buckets, I call it. He's got some inflammatory issues out here that makes him not as responsive in here. So not everybody's going to react the same, and we need to be able to shift and adjust. So testing and retesting gives us a good idea of whether we have promoted health in our patients versus just, is there clinical attachment loss? So here's her retest after that treatment process. So beneficials are still good, which is awesome because some things when we are using antimicrobials, it wipes out the beneficial. So we managed to keep those healthy. The gum inflammation score is lower. Our tooth decay score still average. And then halitosis score is optimal. Gut impact, we still have a little bit of work to do there. I'm going to dive deeper. So I like to show these general information, and then now we're low risk in all of the categories. She was high risk when you look at the oral systemic connections that we tag here. And whoa, what a difference. That's success, you guys. That's success beyond your perio probing and whether there's disease presence. We've actually brought her to health, which is amazing. So we do have a test comparison feature, which I love to dive into. So you can select the test dates that they've done and then compare side by side. So here's the example of the gum inflammation score, because oftentimes those gum inflammation bacteria are tied to those systemic health issues. So breaking it down, we really did a great job at mitigating a lot of those periopathology that are tied to her rheumatoid arthritis and her other inflammatory buckets that she has out here. So pretty profound. And then here are like the Prevotella denticola is taken care of. We've significantly decreased our candida. We still have lipotropia. Lipotropia is one that has to be paired with another pathology like S mutans to be really problematic. So it really, and like I said, it's mostly polymicrobial in nature when we get caries issues. So we've really mitigated her decay risk. Her gut impact, pretty impacted as well. We're still struggling with Campylobacter, so maybe a zinc supplement might be appropriate for her to try to get that down. But overall, great improvement. So that was super, super successful story on that. And she was cool because she didn't present a lot with disease process in the mouth. Like as you could see on her disclosing, like her tissues are pretty pink, stippled, firm. Like she didn't have a lot of bleeding and inflammation present. My next case is a Bristle case. I've been working super close with this individual. He had a full awakening of the health connections and oral health connections and really started doing salivary testing because of his fear of Alzheimer's disease. So he came to me, he's had a couple of us coaching, but I see him honestly about every 3 weeks. Even if he doesn't have a new test, he checks in with me about an hour or so every 3 to 4 weeks, just to make sure he's staying on track with his oral care. And sometimes he just bounces some stuff off me, but he's got a lot of things going on. But in the summer of 2023, he had a situation where he had a bill come to the table and he could not add up the tip and the check. And he felt like, oh my gosh, my mind is going, I think I might be coming down with Alzheimer's disease. So he panicked. Like he went into a complete panic with thinking that he might be suffering or starting to slide into Alzheimer's or issues with his memory. So he does have a Lyme history. He has co-infections with Bartonella. He is starting to show symptoms of MS. and he's starting to show some symptoms of some memory issues as well. We did just recently find out they do have mold exposure. He was pre-diabetic, and he is currently on a CPAP machine for sleep apnea. So he's got a lot of buckets out in left field with his inflammatory responses. And I love this story because he's the complete non-compliance patient. So when we talk about salivary testing, I know a lot of people are like, I can't even get my patient to floss. It's all about education. Patients will learn how their oral health impacts not only their oral health, but their systemic health as well. And it's a real big motivator, especially if they have rheumatoid arthritis or cardiovascular disease or other inflammatory diseases. We know that those pathologies in the mouth are highly tied and connected and correlated and causative of those diseases as well. It's all about cytokines, and I kind of joke like we all know about the cytokines because of COVID and the cytokine storms, but most of our patients are suffering from cytokine storms. If they have rheumatoid arthritis and cardiovascular disease and all of these inflammatory disease, and then you add on these periopathology, it's all the cytokines that we need to be worrying about. So he's non-compliant. When I say non-compliant, this man was literally brushing his teeth maybe once a month when he started with this process. So this is his perio charting. I had to piece everything together. So this is the best I could do with putting his full mouth together. They came one image at a time. So, but significant bone loss on his x-rays, especially where his wisdom teeth are, but even in the molar area and the lower anterior, as you can see the bone loss. But look at his perio charting. 31 has a 14 and 12 millimeter pocket and the linguals. Significant periodontal involvement when he finally makes it to the dentist. So his journey actually started with going to a functional doctor, and they referred him to his dental office because they were putting the oral systemic connection together. So significant bone loss, significant periodontal disease presence. His office ordered DNA connections tests. So I like to share this because other people are using different tests, so it kind of gives me a good idea. So this he shared with me. So this shows some key pathology, and it scared him. So once he got this test, he was like, whoa, this is crazy, and I obviously need to do something about it. So he started on his dental journey and started removing his amalgams. He started LANAP surgery in November, and then was put on dentocidin, biocidin drops, the rinses, and then told to floss. And he was starting to mouth tape with his CPAP. So at the very start, like I said, he started the RECODE program, which is keto based, with Dr. Bredesen at the Apollo Health Center. They have a whole Alzheimer's protocol. It involves 16 hours of fasting. He's on methylene blue, and he's remained keto since August. He also has taken some courses and read on the Terry Wahls protocol. So he kind of goes back and forth with their protocols. I bring this in because our diets matter. Our American diet is a SAD diet, and what our patients are eating matters. So it was super cool, and I think a big impact on his outcome as well. So, and like I said, the functional medicine sent him to a dental practice to get his mouth taken care of. So we need to start doing the same in the dental field. We need to start referring our patients to physicians to deal with the other issues as well. So he did his first Bristle test prior to his LANAP surgery as well, and mostly because that other test was really expensive, and this one gave him really good insights, and it was affordable for him to use and start looking at. So I'm going to kind of compare the tests a little bit with each other, but high gum inflammation, beneficials look pretty decent. Halitosis score, average. Gut impact, average. So overall, it's, I mean, what you would sort of expect with, but not crazy. And that's where even though he's high risk, I mean, even if you look at the pathogens, a lot of the ones that we think about aren't really present there. But he's got all of the Lyme disease and sleep apnea also contributing to his inflammatory buckets. So that's something super key as well. There is TF and T. denticola, so that's high where the Alzheimer's kind of comes into play as well. But so here's the pathogens kind of close up to really understand which ones were actually within his oral microbiome driving his inflammation, gum inflammation score to that 7.4. And then here, for those of you who are using different tests, this is kind of a little bit of a comparison. I kind of had to pull some of the other tests. We do test for most of these pathogens. They might just be in different scores, so you can find them in our tests. They did kind of correlate with each other. We don't test for Entamoeba. I love that on the microscope, super fun. So Entamoeba gingivalis is a single cell protozoa. It affects the immune system by eating the white blood cells. So we don't want those present in the mouth. But I just wanted to give you a quick kind of compare to see how our test kind of compares. Now, our test uses a different technology than PCR testing, so it's a little bit more comprehensive in nature. So for the Bristle testing, we kept him obviously on the methylene blue. If anyone's not familiar with methylene blue, it helps with mitochondria function. So I think that's a really cool adjunctive therapy that also helped with us. But mitochondria are really important for healing and cell function, if with cell regeneration and things like that. So I wanted to put that in there because I think that that also is a contributing factor to his outcomes. He started oil pulling in the morning. I'm a huge fan of oil pulling. It's antimicrobial, antifungal. The one I put him on had some antimicrobials as well. He was put on an electric toothbrush. I always demo everything. I'm always up in the camera doing the demo on stuff. I think it's important for us to show patients how to floss and brush properly. Tongue scraping, water flosser with a hydrogen peroxide, 1 part to 3 parts water to take care of those anaerobic bacteria, get more oxygen below the gum line. Basic bites for pH and helping with those nitrate reducing bacteria. Nitrate chews, xylitol to help with pH balance throughout the day, and then Bristle probiotics. He was using Denticidin toothpaste and the Denticidin liposomal drops. I do like that product as well. So rather than putting him on a more traditional, he was already sort of on that more holistic side of things as well. So I just kept him on that. And then of course, disclosing solution. I wanted to know whether or not he knew if he was doing good plaque removal. So he was told to use that. This is a second test. So in between the Bristle tests, he did have Lenap's treatment at his office. So he did have laser treatment within the office, and he showed a significant improvement. This is a big wow. I don't always get to see these changes this quickly, but he was serious about what he was doing. He changed his diet, and he was really adamant about making sure his home care routine was improved so that he could make a difference. Because like I said, he's got Lyme he's dealing with, possible MS that he's afraid of, and then the Alzheimer's aspect of it as well. So taking a little bit of a closer look, the gum inflammation score here, we just have F that's still high, but everything else is really in good shape. So here's a closer look comparing the two tests side by side so you can see where those changes were. I like the compare option where you can open it up and really look at what the growth was. So sometimes the risk score won't always shift as much, but I like comparing so you can actually see what did shift, because sometimes the patient will get really disappointed, like, wow, I went from 6.4 to 5.4. That wasn't really that significant. Open up the compare and look at the pathology, because that gives them more hope on what the changes were. So there's certain bacteria that'll have a higher score depending on the risk factor. So I basically just kept him on the same protocol because it wasn't affecting his beneficial bacteria, and we still had a little bit of the TF to deal with as well. And then he was already started to fall off the the regular routine. Maybe he was just doing it once a day and not twice a day. So I was like, nope, we got to stay focused. So, and we get a third test. So there was a little bit of shifting with the third test. We need to start paying attention to the nitric oxide issue that's sliding, but the gum inflammation score is looking pretty decent. But all of a sudden, the tooth decay score was a little bit wonky. But look at his perio, guys. Like, we've resolved a lot of the perio, which is awesome. Fusobacterium, I see it there. I don't see Fusobacterium at 0 hardly ever. So I think this is a pretty profound improvement for him. So we're still doing kind of the same routine, but each time I meet with him, we're just reiterating that importance of the good routine. Let's just talk about the tooth decay score for a second. So he's taking oral probiotics. His tooth decay score is high because of Lactobacillus plantar, which is in the oral probiotic. So I'm going to just explain this because you're going to start seeing this if you're using oral probiotics. So Lactobacillus plantar helps to correct and disrupt strep mutans and Candida albicans. Lactobacillus plantar can kind of stick into a current decay issue. So there's two things that could be going on here. Either he has a little bit of active decay somewhere that's not showing necessarily up on his x-rays, and that Lactobacillus plantar is sticking in that spot, or he did the test too soon or too close to taking his oral probiotics. So those are the two. It doesn't cause a risk, but it might be a flag that there might be some area of possible active decay because it will stick in that area, but it doesn't ferment and cause cavities. And then this is what happened with the nitric oxide score. So in my experience, Granulocentella adicans has grown. It's at 10. That's a tongue coating bacteria. It can be a high risk bacteria for halitosis. I struggle with this one. This one I struggle with. It's facultative, it's not sensitive, and it's gram negative. It's a hard bacteria. Granulocentella adicans will be high with antimicrobial sometimes. And as an oral health coach, I'm going to say I'm struggling to figure out how to get rid of this one. But because it's tongue coating, he's reiterated, make sure you're tongue scraping with a metal tongue scraper, doing it twice a day, because the tongue coating bacteria will mitigate your nitrate reducing bacteria. This is the reason why. Most of the bacteria that are causing nitrate reduction are aerobic or facultative bacteria that thrive on the tongue. So when you have high tongue coating halitosis bacteria, they form a biofilm on the tongue, which snuffs out those aerobic bacteria, and then you get low nitric oxide. So tongue scraping is super important, and making sure we're incorporating nitrate-rich foods like beets, arugula, spinach, or maybe doing a nitrate supplement will help shift that as well. So that's why his nitric oxide score was low. So, and then he uses a CPAP too. So I think sometimes that can be problematic if he's dropping his mouth open as well. So nitric oxide, another thing that can be flagged as mouth breathing, will also have nitric oxide reduction with the bacteria. So when you see nitric oxide, check the tongue coating bacteria if it's a low, and then always check airway as well. Now look at his x-ray or his perio charting. This is profound. So that 14 millimeter pocket is now a 3 in February, and 6 millimeter is a 3. I mean, his perio charting is immensely improved. Amazing. This is a really cool. We got his biome under control. He's working on his diet and his inflammatory issues systemically, and it's showing in the mouth. Now he has his wisdom teeth. I have encouraged him to have his wisdom teeth removed because he's going to have areas where he's just not going to be able to resolve due to the way that his wisdom teeth are presenting. So we did have a conversation about having those removed, but wow, hard work pays off. And your non-compliant patients can become completely compliant with good education and proper coaching. So it's so cool to see. I'm so proud of them. So remember to retest, because true health is really making sure that we're mitigating bacteria that also have an inflammatory response with the body and in the mouth. So thank you. We're going to open it up to questions.
Awesome. Thank you so much, Heather. Incredible presentation. And thank you everyone for the questions. So we'll just run through them as they came in. So Megan had asked, do you find that guided biofilm therapy shifts the microbiome at all, or do the same bugs keep growing back? Is it possible to encourage certain types of bacteria over others? Or put another way, could guided biofilm therapy shift the microbiome to something worse?
It probably could. Anytime that we're completely wiping out stuff, there's a disbalance in the process of going forward. So if you're even in your regular hygiene routines, I think it's important that you always incorporate pH hygiene. So xylitol, I think it's important that we're focusing on growing good bacteria. There's products like Revitin out there that are probiotic in nature. Feed Your Good Guys is a new product that has arginine and xylitol and hydroxyapatite and no sodium lauryl sulfate. And then probiotics make a huge difference as well. So anytime we're doing anything in the mouth, we can shift it either way. So if we're disrupting something, we need to change the environment so we're catering to the good bacteria to thrive in that environment. If I wipe out the garden and I don't put my tomato plants in there, I'm never going to get tomato plants. So yeah, it definitely can. Overall, my patients with guided biofilm therapy, everyone improved, especially my perio patients.
Great, very well put. And yes, so there's always the weed, seed, and feed phase, as we've borrowed from very much in the gut health. So Sandra had asked, what's the maintenance protocol? How do you keep your healthy patients from going back to disease state?
And that's where testing and retesting comes in. So once you kind of establish where they're at, I think probiotics are something you should have to do probably regularly, and then keeping diets. And so it's always a maintenance process. It's that cycle if someone's more prone to issues. So I think home care really makes a big difference. And it's not about giving them antimicrobial rinses. It's about balancing the garden. So making sure that they have a good diet that's feeding beneficial bacteria, promoting pH balancing situations helps to grow the beneficial bacteria. And then maybe you have to test once or twice a year, depending on the patient, and you'll find where you need to test. If anyone goes on an antibiotic, they need to be tested, and they're going to need a protocol because it wipes out everything. The decay bacteria will be high all of a sudden, and it causes dysbiosis.
Which is a great lead in into the next question from Christine, which is, when do you recommend antibiotics?
So we do have guidances with antibiotics when the pathology that we have in our test indicate that they're needed. So in our office guide, there are some recommendations for antibiotics. As a dental hygienist, I've never used antibiotics in practice just because the doctors I've worked for have never utilized them. And the individual that I just showed you who had the 12mm pockets, we did that without antibiotics. So it can be done. Antibiotics causes a severe gut dysbiosis. P. gingivalis right now is showing some signs of being more resistant to antibiotics. So I sit on the holistic side of like, let's try to find ways that we can mitigate the bacteria and not use antibiotics. But I know there's some offices that do use them, and like Granny Centella Atticans, maybe I would want to use against because I just can't get that one under control. But I think, yeah, we have guidances in there, and it's really based on what bacteria is present in the levels. When it would be needed, Bristle has the recommendations in there for your guidance.
Yep. Great. Thank you, Heather. Last question in here is, how soon is too soon to test after taking oral probiotics or anything taken by the mouth, like water, food, or even brushing?
So generally, we want patients at least, so if they're coming to the office and you're testing, we want them to not brush for or do anything for at least an hour prior to coming into the office. If not, if you can hold them off in general. Usually if someone's doing the test, we say brush your normal routine at night and then do the salivary test first thing in the morning. And some of the ways that I kind of incorporate, if you have someone that you didn't do the test at the very beginning and then you get them sat back and you're like, hey, we probably should have done a test, then you need to wait 3 weeks after your treatment to let the biome settle back in, or you're just testing your prophy. So I usually say give 3 weeks for the body to rebalance and really do a good assessment on what's settled into the garden before you're testing. A good way to do that is, and if you, I recommend this for like say you have a perio patient and you want them to test, it takes about 3 to 4 weeks for us to get you your test. So if they're coming back in 3 months, send them their test. This is the old one. I don't have one of the, send them their test, next visit date on here, and then 4 weeks before that, test date. They can test 4 weeks prior to, send it in, and then hopefully you have the test by the time they come in for you to review. So that's a good way to do it, to have a good current test if you're going to send them home with a test. Or just for perio maintenance or any recare, it just kind of takes the work out of it.
Awesome. Thank you, Heather. We did get one more question, so I'll read that off here. It says, my hygienists are having a hard time discerning why we are testing if it isn't changing their treatment plan. For instance, if NSPT with laser and or ozone is the go-to protocol for perio, how does testing change the course of action?
Awesome. So for your perio patients, it may not, but here's the key. There are so many other patients in your office that are perio patients. They're not presenting with disease. So that's where you're going to have your shift with what you're changing. So like I said, the patient that the first patient I presented, she didn't have signs, really true signs that she was inflamed or problematic. And I see tests, hundreds of tests. And there's so many people who don't have, I get a lot of people who have halitosis issues. So they're testing for halitosis and I get the test. They don't have, like the office tells them everything looks fine. Tissue looks great. There's no cavity issues, pink stippled firm tissue. But when I look at the test, they're a perio nightmare or they're a caries nightmare. So that's where you're going to start seeing shifts. You're going to start treating preventively before the disease process even takes place. So that's where you're going to start adding more treatment, is with your healthy patients who are not healthy. And I'm sorry, but a 43, 46 at 30% bleeding is not like, our 1110s have to be 30% bleeding before we can treat them for disease. So it's thinking outside the box, like let's do a diagnostic test to see your risk and actually treat the pathology that we know is tied to your oral and systemic health, and not just do a 1110 see in 6 months.
Very well put, Heather. And just wanted to also chime in that if any team members ever have questions about Bristle results, about learning more about testing, about how this can help guide your care, Heather does lead our training, so always open to speak with them. We did have one last question. Actually, we have two more, but I know we're getting late, so we'll run through these very quickly. One is, can you detect H. pylori from oral microbiome testing?
Yes, H. pylori is in our test results, and so is herpes simplex So we have some patients who may have like burning tongue syndrome, and sometimes herpes simplex will show in the test results as well. So yes, you can find H. pylori in there.
Awesome. Thank you so much, Heather, and thank you so much, everyone, for joining and for the great questions. For anyone who isn't currently working with Bristle testing but is interested in learning more, I've just dropped a link in the chat to our provider page. You can also find it at bristlehealth.com/providers, and we'll also be sending an email with this recording that has more information. So if you want to set up time to speak with Heather or I, answer any questions you have about Bristle testing and how it can fit into your practice, we're looking forward to meeting you. So thank you so much again, everyone, for attending, and huge thank you, Heather, for the wonderful presentation. And we're excited to be working with all of you. Thanks so much for making the time to help improve oral health and care. Have a great night. Bye, everyone.